Okay, welcome everybody. My name is Tara Humphrey and I am the CEO of an organisation called THC Primary Care. And predominantly we provide interim management to primary care networks. The business has been going for 8 years. So we were kind of here before primary care networks, but kind of pivoted our support. I run the company with a small team. I think there's around 10 of us. Employed, and we also use a couple of contractors. And last year we started a webinar series called The Role of the PCN ... And that was to help a kind of bit selfish endeavour. It's like I've got potentially, at the time there were 17 roles. I think there were a few more. I think there were around 22 roles. Trying to understand what each of the roles do. So we're slowly working through them. A lot of that information is in one of our primary care network courses, but for some of the, I'd say, not as popular roles, we definitely want to disperse this information as wide as possible. So typically I will see people online and be like, oh, they do this or they do that. And Melissa, I can't remember. I think I may have reached out to you, but I was like, oh my God, I've been looking for an OT because you guys are pretty rare. So reached out to Melissa and asked her if she would kindly do a webinar. So Melissa, could you introduce yourself? What do you do and where do you work?
So, hi everyone, my name is Melissa. I'm an occupational therapist by background, but work as a mental health practitioner in 4 surgeries in Hertfordshire. So that's me. Tara, I think you did reach out, and I think you had shared a podcast about someone with type 1 diabetes. So that's how we connected.
Yes, and my daughter's got type 1 diabetes, and so is Melissa. So you've got like a hybrid. I'd say even you're rare because you are both an OT and you work as a mental health practitioner. So can we start? What attracted you to the role?
So what attracted me to the role is that I've been an OT for just over 3 years in December. So I'd done 3 rotations already. So my first rotation was in specialist learning disabilities. My second one was in acute and crisis. And I did a bit of inpatient mental health. So I saw the job online and I thought, why not apply? And the rest is history. So I've now been in 4 surgeries across Hertfordshire. So each surgery I think is different because the one on a Friday I work for caters up to 15,000 patients. It coincides with a university campus, so 5,000 of those patients are university students. So obviously it's sort of adapting patients with low mood and anxiety. We're still seeing patients coming out of post-COVID and the impact it's having on them. Sort of just building awareness of how they can still build routine and practice into their lives. And also just understanding what's impacted their mental health so they can still aid a form of recovery back into the society.
Okay, so do you count, so where you are an OT by background and you're in the role, you're in a slightly different role, are you utilising your OT skills?
Yes, pretty much every day. There's not a day I don't use my OT skills. So like, for example, this week I've had a patient who was 50. They didn't want to have any medication. They came in for sleep insomnia and routine planning. So I did, like, in our surgery, I've developed my own pro forma, as I would say, just to screen patients based on the OT values, model of human occupation, which is some theory done by C. Parkinson. So I asked the questions like, how is like your activities of daily living, like eating, sleeping, do you go to work? So obviously we would discuss the social prescribers if they need the support with benefits or food banks or anything like that. Then what is their goal is where I sort of step in. So I sent them some sleep hygiene techniques from the NHS website online. I talked about the blue light, obviously removing any devices after 9 p.m, cutting down the caffeine. I'm actually due to see that patient in 2 weeks' time. So I've set them on their goal and see how they'll go, and then they'll come back to me and discuss.
Okay, I just wanted to ask if any of you, those of you in the chat, would you be able to share whereabouts you work and what you do in your primary care network? Because I think that would be really, really helpful. Melissa, would you be able to share, like, what does your team look like? Because you work as an MDT, don't you? So who Who do you work with on a regular basis, and how's your team organised?
So we're in a small team of 6. So we have one specialist nurse who does some prescribing. But in our area at the moment, the GP still want to prescribe the medication, but she'll still have an active role in saying, oh, for example, sertraline is the first line that is usually started for patients. So she may say to GPs, oh, they've been on this for 4 weeks, maybe let's try something else. Then we have a recovery practitioner who is amazing in our team. She leads anxiety management groups, which I think is now in the second phase now, post-COVID, face-to-face, which we're all loving because it was all virtual. So she's sort of delving deep to understand what is anxiety, the symptoms, the physical stressors, what makes our patients anxious. Is it going to the shops? Is it going to hospital appointments? And then she may do some like therapeutic work on a one-to-one basis as well. And how do they cope with anxiety? So they may do some like box breathing techniques. They may be given some homework like a stress bucket, or other ones is where you write what your worries on paper, but also just trying to understand what's going on. Are they realistic versus unrealistic? But she's also developed some great resources, which is amazing. Then we have 2 lovely support workers in our team who do the outreach. Um, Amazing people. So they will go and see the patients at home after my colleague and I have assessed them. They may sort of teach them how to go back into the community. They may say, we're just going to walk to your front door today, and then say front door today, and then try that for a few weeks. Then front door may change, so we're going to walk into town. Really doing it at the client's pace, because sometimes when we say you need to go to town now, a client feels apprehensive and may not want to see you again. So it's just really going at their own pace and speed. They also help them like just finding local groups, so like women shared, men shared, befriender services, also signposting to other services that are in the area. We are seeing a lot of patients who've had bereavement, so they may find some counselling services or make some counselling referrals for them. The list is long, but
Okay.
And then there's me. I'm the OT. I still assess patients. Sometimes I will make referrals to adult social care if I feel there's need. I will discuss with the GP, but we work in coincide, like every day we work together. We have our meeting every week where we discuss our patients that we are worried about, but also just working how we can plan them together and see what needs to be done to make them more independent.
Do you feel, how long have you been in your role?
So I've been in this role since January.
Okay. Do you feel like the lines of communication and the roles and responsibilities across your team are really clear, or sometimes you find yourself stepping, like, do you step on each other's toes? Not in a horrible way, but is it really clear what you each do?
Yeah, so it's very clear what we do, because even in our team we have a role checklist that has been developed by our clinical nurse specialists, and it's also shared with the social prescribers, the health coaches, and the care coordination as well. So we have a clear outline pathway. So sometimes I use that when I'm assessing patients, like, oh, let me just check this. Do you think this will be appropriate or not? Because again, a lot of patients we've seen are still paying for their prescription. They're not unaware of the prepaid certificate. Yet, as you know, with the cost of living, £9.50 is a lot, and obviously some patients may choose between eating and a prescription. So it's all these things, but we use that leaflet. But we work inside. Like there's days we check in every day, and there's not a day no one calls one another in the team.
Okay. How do you carry a caseload?
So I don't carry a caseload, but I can see patients up to 4 sessions. So I'm technically classed as an R, a reimbursement scheme role is my role, but I see patients maybe up to 4 to 6 sessions, but I try and make sure there's no more than 4 sessions. If there is, then I would sort of say to our support workers in the team, can you perhaps see this patient a bit longer if I feel they need longer term intervention? There are cases sometimes where patients need more than 6 weeks if their case is a bit complex, but I don't hold anyone physically on a caseload, because in primary care that's virtually impossible. They come and then you have to sort of try and deal with your consultation half an hour and see what can be done today, and then maybe book a follow-up the next day.
So your consultations are half an hour, and are people referred to you, or would you consider yourself like first contact? Can people come directly to you?
So in our patch, they see the GP for 10 minutes, and the GP will raise the issues, and then the GP signposts them to us. Obviously, we know our GPs are very tight, the time is very stretched. So they'll say, I'm going to refer you to the mental health practitioners. They'll call you within 5 to 7 days. We sometimes call them earlier. So my colleague and I call them, and then we arrange that first contact, whether it's face to face or in person. But it's down to the patient what they prefer.
Okay. And how do you know that you're doing a good job?
So recently, I've actually developed a feedback tool, so patients can actually say like whether the service has benefited them, yes or no. And a lot of the feedback has been quite positive. So between February till now, I've seen about 200 patients. 200 patients. So that's about 32 patient contacts per week. And obviously the GPs, we've seen an increase, like praise in what we're doing, and obviously recognition as well.
So Joe's just said, and I think a lot of roles find this, her OT works as part of an MDT frailty team employed at Band 7, but feels underutilised. It's come from high-level experience in secondary care. She's a trailblazer and hoping to shape pathways, overcome barriers in her current scope. How you've been in post since January, it sounds like you've got a very forward-thinking PCN in regards to how your MDT is structured. Do you feel utilised? And if you do, how have you and your team managed to get the network to understand what it is you do and to make sure you're nice and busy but not overworked?
So to answer your question, Joe, so my colleague who's the nurse specialist will deal with the med side. I will do more the anxiety routine, structure and planning. So I try and do stuff that is OT based to ensure that I'm still utilising my skills. We also sometimes work in coincide. So if my colleague is doing something medication related, I will still do my bit as OT. But also just bringing, I think what we did at the first beginning when I started, we brought a meeting to the PCN of what I could do as an OT. So actually just showing that you've employed an OT, you may think, oh, an OT can't do anything. I've actually shown them like what I could do in the surgery. Obviously, there are times where I want to make a cup of tea with the patient to assess them making a cup of tea. Then I have to pull myself back and say, Melissa, you cannot bring a kettle into the consultation room. You can't start making sandwiches. But just really having that open discussion with the PCN, like as an OT, my role is this is what I can do, being adaptive. There's one patient at the very beginning I did a Montreal cognitive assessment with. I just brought some like dominoes in and she just started, we had a small quick game. So just being very creative and adaptive with our line of work. Obviously, I think our court has, Royal College of OT has the statement of improving lives mandate. So just being very adaptable in practice.
Can I just say, I'll come back to that, but can you just, if you were talking to an alien and they did not know anything about general practice and you said, I'm an OT, and they said, what's an OT? What would be your elevator pitch? What is it succinctly that you do to help people?
So, Tara, so I would say to the patient, I'm an occupational therapist that is trying to get you back to living independently. What would you like to do? What would you like to do? And what is your goal with me? What do you want me to help you with in order to be independent?
Where does your social prescriber come in?
So the social prescriber comes in after the consultation. So sometimes a patient may say to you, I just want help with finances.
Yeah.
But then obviously, like I may dig in deeper. Like I had a lady this morning who's struggling to walk. She's got a bad gait. Her rollator frame is broken, and she's got a wheelchair. So she's saying she wants to go out. So in that case, I was asking, like, do you experience pain? How much is the pain? In the end, I said to her, has NOT come out to assess your home environment because she also has epilepsy, to assess whether you need a pendant alarm, whether you need rails put in. And they said, no one has come out to my house. So that's where I've sort of done a short piece of a short referral to adult social care to refer her for that piece of work.
Okay. Whereabouts do you work? From home, in practice? Would you go out, or both?
So I do both. Obviously, on a Monday I work from home all day because obviously, as you know, the practice is the space is limited. But I usually go to the surgeries in the afternoon, apart from a Friday when I've got space all day at surgery. I'd love to go to the patient's homes, but obviously that's not part of the primary care plan yet in the NHS. long-term plan, but who knows to say, it might come back.
Okay. So just going back to what Jo says, and every role, well, not every role, lots of roles experiences, it's the overcoming barriers. So what barriers have you encountered in your role to date?
I think one is room space has been challenging because you have some patients who actually want to see you in person. So I've had a few patients who've got hearing aids, or they have some form of visual impairment and they want to come to the surgery with a loved one. The other thing I've found an issue is the rotoring system, because especially in our Friday surgery for the university, we're booking maybe 4 weeks ahead, and sometimes the rooms don't get allocated maybe to like a few days before. So those are some of the barriers that we face. And I think the final one I would touch on is just accessibility to some of the services. So for instance, I think a patient needed referred elsewhere to another secondary services that took very long. So the patient just gets frustrated, and then obviously complaints take place, and then you're trying to work out what's gone on. But I think in our team, we do reflect on that quite often of what we could have done differently.
Okay. Do you go to PCN meetings outside of your MDT meeting?
So yeah, we do go to the PCN meetings. We're also involved in the patient forum groups. So this week we did a mental health talk, which was quite nice to hear patients tell patients about our mental health services. A lot of the patients didn't actually know we existed. Obviously, that was a breakdown in communication for them. But obviously, I think I'm now going to be hopefully going to some of those meetings to address some of the issues raised and see how we can say much more about the service, because I think they didn't know it existed or didn't know it was there. A lot of them were like, how long has this service been there for? And then we were explaining that.
Okay. And if you guys have got any questions or clarifying questions that you have from Melissa, please just pop it in the chat. What national support is available for your roles, especially in a primary care network perspective? Like if you're a manager, like we've got WhatsApp groups, pharmacists have got CPPE, like where do you go if you're an OT?
So in our team, we have a WhatsApp group and we debrief pretty much every day. As an occupational therapist, there is the Royal College of OT. There is a primary care network monthly meeting, which is set up by Jen Smith. So that's quite useful. There's also a newsletter that goes out. The Royal College has a lot of resources available. The HCPC is there, but I think it's more just like practical guidance on the registration aspect. But also there's a few Facebook groups as well for OTs working in primary care as well.
Okay. What if you were speaking to somebody that's brand new in their role? So what advice would you give them? Brand new OT, they have no idea about primary care networks and they're the first one.
I think what I would say if I was going back to myself, I'd say use Twitter more, because primary care there is I could list people who've worked in the primary care. I think using Twitter as a platform is amazing. I think take some positive risk taking. There'll be days you get it right, days you don't get it right, but obviously that's part of learning. We all reflect in action and non-action on situations. Utilize the skills that you've learned from other jobs. It's not all one size fits all, and you can be adaptable and be creative in everything you do. And the final thing I say is have fun, because primary care is every day is different. Like this week has been totally different. I did extended hours, 11 till 8. I usually work 8 till 6. You'll have patients DNA in the hot weather versus the winter, so it's all just very different. And I think it opens those inquiries, like why are patients not attending despite them making that first contact for the surgery? What is preventing them coming to the appointments? And what will you do differently to improve patient outcomes? Because in either way, we're sort of reducing the health risks for these patients, obviously as part of the NHS long-term plan, but also maybe the health and the qualities. We've seen a lot of patients from BAME ethnic groups come to the surgery now to seek support around their mental health. You ask yourself, is it because they've gone with a loved one, that first step through the door? Then they can say, oh, I don't need to go with you, but I'll call you afterwards. Like I've seen that in real situations with patients, and it's quite nice.
Do you have clinical supervision?
Yeah, so I have supervision twice. So I have supervision by a nurse, and then I have supervision by an OT. So I have that once a month, but also if I need to chat to them outside, they're always available on hand.
Just actually, I did think, Melissa, that you are not a good example, because it sounds like you've got so much support, which is amazing. You're in a fantastic example. So many networks don't have that, but it is great. You are a fantastic example, but I know there'll be so many people thinking, don't have that, I don't have that, I don't have that. When you mentioned enhanced access, you did make me think. I just written a blog called What to Focus on in Q2, and I do invite people to start thinking about like winter pressures. What is the role of an OT? Do you anticipate your role changing, increasing to accommodate the winter? Like, what is it that you can bring to that conversation to help with planning your time and being proactive with your community?
I think we will definitely see a difference in winter. We're already seeing it in summer that there has been some decline in patients coming to surgeries. We're seeing a lot of patients now opting for telephone than in person, but then obviously you don't know if they're masking. Winter pressures will be different because obviously a lot of patients say they're a lot worse, their mental health gets a lot worse. So maybe as a team, whether we start thinking about video contact perhaps, but then again, we have to make sure it's accessible because not everyone uses video. I think really seeing what they all need. So obviously it's a bit hard to tell because we haven't quite not got into winter, but also we will anticipate a rise in referrals out in the winter months because you've got Christmas, you've got all these anniversary months that could be sad to someone, but also it can have a detrimental impact on their health and well-being as well. So it's very hard to tell yet. But it'll be interesting when it comes to winter.
Yeah. Okay, we've got a few questions. And Joe says, can you share in the chat details of the social media groups so she can share with her OTs in case they're unaware? Much appreciated. So yeah, if you could do that before you leave, that would be fantastic. Or any, I think you mentioned, and I found you on Twitter. I always say to people like, actually, no, this is being recorded, I won't say it, but yeah, lots of people hang out on Twitter and it is fantastic. Sue says they've got a county-wide PCN OT network, amazing, as well as local OT meetings, which is great. Do you know how to access OT supervision out of area? Our OT only has a nurse and medical supervision, but own supervision and own profession supervisor is important. So Melissa, where and who is your OT supervisor?
So my OT supervisor is in the same area, but she just works in another patch. So obviously she's now going to be working in an enhanced primary care team, which is something that we're going to be setting up in a couple of months' time. So she works maybe like 30 minutes away from me, but we have supervision online or in person. But she works for the trust, same trust as I do. I was going to say to Joe, your OT colleagues, if they contact the Royal College of OT, if they get that, there'll be a section in the magazine and then a contact in there. I think it's Jen Smith is the one. She can give you most of the Facebook groups as well, because there's loads that she can suggest. But if your OTs are part of the Royal College of OT, they'll be able to find her contact details in the Royal College of OT magazine.
And who facilitated your OT supervision? Was it you or was it your clinical supervisor?
So at the very beginning, I've always been managed by a nurse, and the nurse manager that I had was like, it's valuable that we have OT supervision as part of continuity. Obviously, most occupational therapists know the audit is coming in a couple of months' time. So it's vital as part of the HB standards to have that OT supervision. So hence I have two hours of supervision per month, but I think it's valuable because we all bring something different to the table.
Okay. I
was going to say the only thing is that obviously, say if I had a case that I was a bit apprehensive of, I'd contact the duty doctor if I was in the surgery. That would be for supervision and guidance and establishing whether that patient needs to go to secondary care.
Okay. What should we be looking for when we're hiring an OT?
This one, when I saw this question, it was a bit of a tough question because OT is unique, and obviously we work in different skills. Our skills are transferable, but I think it's asking yourself, if you're the one who's put the ad out, what are you hoping to achieve by having an OT in your service? When I applied for this job, it was either nurse, social work, or OT, but at least we all bring something different. And also, what's to say that I think I actually spent a day at this place before I applied, but I think it's just what are you hoping to achieve, and how would you want that to transpire into your career journey and mapping. So I think for one of my aims on my on my PDP, professional development plan, is I'd hope to use this role to sort of pursue some research in diabetes and OT. And obviously we do see a lot of patients in primary care with diabetes and the health inequalities.
I think that question is, and the point of doing these webinars is that I think most managers won't understand what the role is. A lot of CDs don't understand what the role is. So they'll be thinking, why do we need an OT? Like, I don't understand what it is, like the value that they bring. But I'd also say, from outside of the kind of technical skills, it's very likely that most OTs will be like the first person, they'll be the trailblazer. So they do need, like resilience. And I know resilience is, you don't just have it, you develop it. So it's like you need to have the mindset of, this is like it's long term, it's a long term role. You need to be visible, and it's always about not being frightened to repeat yourself, not being frightened to say, this is what I do, here's an example, this is what I do, because I think that this role, and there are other roles, I would say like a podiatrist, I don't know any networks that have got a PCN podiatrist. There are certain roles that they're just in a primary care network setting are not widely utilised due to the lack of understanding. So I think you just need oodles and oodles and oodles of patience. Definitely. Oh, my screen's just changed. So, where did you find the job ad?
So for me, the job ad was being advertised on the NHS jobs in our trust. So I rang the lady and then I applied. Initially, I'd actually got the job in June of last year. Then I did take it, and then I slowly regretted my choices as the months went on. And then I contacted her back in November. Then she has happily accepted my offer to take it again.
Okay. And how did you, when you said you spent a day there before you got the job, or did you apply? Like, how did that come about?
So I just, as most jobs, sometimes with them, I just asked to spend like a couple of hours. So I just spent a couple of hours, but it ended up turning up to be like just a conversation. And obviously, we had a chat about the role, and I think there was times to go, but then obviously in my previous job, we went back into COVID measures. So I didn't think it was quite safe to go to that place because we were in a COVID lockdown in the ward, and then going to the community, that would have been practical and the best idea. But we even had more of a conversation, but that was what I had planned to spend a couple of hours just shadowing. But I know one of our colleagues that's recently joined the team did that, and she found that beneficial as well.
It's really good. Sam says, how do you demonstrate the value, your value as an OT? Do you use any outcome measures?
So Sam, I do use some outcome measures. So I think at the beginning I mentioned I created like a survey tool using like a scale. So of 1 to 10 using smiley faces. My first OT supervisor sort of reminded me like what you get at the petrol station or the airport, where you're ranking the toilet or the airport service of that day. So I sort of used that, and it's quite friendly, so people can just rank that. At the beginning, when a patient sees me, I will rank their mood of 1 to 10 as well, using a similar model, so I can justify whether by having the intervention has it improved or not.
Okay. I think demonstrating the value is so key, and I think you have to keep communicating that, saying this is what we did, this is what we've achieved, this is what the patients say.
Yeah.
training, have you had any, have you had or do you need any further training to support your development?
So I've already had sensory training from my last job. I was fortunate enough to have gone to the Royal College of OT conference a few weeks ago. In our trust, we're sort of just working out what training's available, because technically I'm an OT, but there's nothing really for primary care. So I'm going to be doing some personality disorder training in a couple of months,
Yep.
which would be quite good. And I think there was talks about doing some AMPS training, so the assessment, motor and skills training, but then we don't know like who would pay for it, whether it be the PCN or whether it be the trust. So all the nitty gritties of the financial side is sort of coming out. But I think there is room for training. There's always some training in our trust that's going on, and the GPs are supportive if I want to do something outside of the trust. Like I was fortunate enough to do the Elizabeth Casson leadership program, which is just finished. They're looking for mentors at the moment, but also they fund grants if someone wants to do further training, masters, or go to conferences. So that's also another way to seek funds as well.
So I'm really sorry. I think I've missed this. Who employs you?
So I work for the primary care network, but I'm employed by NHS. So that's how it works. But then when it comes down to the money side, the NHS puts a bit and the PCNs puts a bit into to pay my wages. That's how it's been explained to me.
Okay. Okay. So when you say that, so you're employed by your trust, and it may not matter. No, I think it does matter. So you are, so do you know, are you down as an OT or a mental health practitioner?
So when I open up my payslip, my title is mental health practitioner on it.
Okay.
But obviously when I talk to patients, because of the whole, we've had a few patients say, can you prescribe this? I give that disclaimer at the very beginning. By background, I'm an occupational therapist. If you discuss anything about medication, this will have to go back to the doctors or the prescribing nurse. That's like my opening statement to them, because some patients will want you to prescribe there and then, which is outside of my scope of practice.
Okay, I just want to double check something. That's interesting. So hopefully when managers see this and CDs see this, they will think that is interesting that you're being funded via that route and not down the OT route. But I suppose, yeah, every area does it slightly differently, and it doesn't, ultimately you're there, you're doing the job, and everybody seems to be happy. Do you ever feel like, where is your home? Where do you feel like you belong? Trust or PCN?
I think the PCNs, I think it's both, but I think the PCNs really value our input, because obviously, like one of our surgeries had 65 tasks when we first started,
Yeah.
and now it's down to 10. So I think the PCNs are really seeing the work we do, and I think it's that conversation, that therapeutic relationship, because I think I saw one the other day, and they were like, oh, thank you for sorting this one out. I didn't know that was a service in place. And then it's just, the conversation starts. And I think it's just quite nice. I will say I'll put my email in the chat if anyone wants to ask me about anything offline, like I think I mentioned about the flow chart that we use for patients.
Yeah, that'd be good. Yeah.
So I'll put that in the chat.
And just for those people listening in and they can't see the chat, we've got a few OTs here supporting frailty and falls. So hopefully you've got some good examples of how to utilise an OT in your primary care network. I'm just trying to, let me just double check to make sure I have covered everything. Final thoughts. So you've said, or kind of, and I know it's an obvious statement, but when looking for an OT, you really have to think about, you know, what it is you're trying to achieve. You've talked about, it sounds like your network is really forward thinking. You've created clarity in regards to your roles checklist, so you all complement each other, and you've got that relationship where you can just pick up the phone. So my kind of, if you are a clinical director or manager listening in or watching in on this, is to try to do that before, or just be really upfront that you want your OT to help you create that clarity. In an ideal world, you'd walk into it and it'd be like, this is the role, now make it your own. But in many instances, it's like they come in like, what do you do? Can you help? And then you're kind of building the plane whilst you're flying it. And I would say, yeah, just be upfront, make sure you've got that role clarity. Clinical supervision is so, so, so important, and have dedicated time. You talked about you're not going to meetings and you've kind of got your outcomes, so just sharing that. So it's just all the things, these I'd say like they're the fundamentals and the basics, but sometimes these things slip because it's so busy. It's so, so busy, and you kind of like, you stumble like, oh, I should have done that. Oh, I should have done that. Oh, I should have done that. So I think a lot of patience and planning is required on both sides. Do you have any final tips for a PCN management team thinking about bringing an OT in? Like, what would be like your one piece of advice you would want to leave with them?
Oh, Tara, you put me on the spot. I think first of all, there was a Royal College of OT article done in October by another Rs worker, so I would suggest the PCN directors check that out. Secondly, if it doesn't work, that's okay. If it does, that's great. You don't know if you don't try. And I think having an OT is part of the NHS long-term plan. It's something that we are seeing, like we're going to have paramedics, we're going to have podiatrists, we're going to have physios in the surgery. So why not expand the team now? We don't know what the government will do. Each day's new for all of us, but just give it a go. The worst they could say is, oh, it hasn't worked out, that's it. But don't leave it too late. And the final thing I'll say is discuss with the Royal College of OT. I'm sure they'll happily discuss like role descriptions with you and other things. Like it becomes what you want it. It becomes what you make it. It's what you want it to be.
Yeah.
So without you think bold, think brave, and be curious is what I'll leave you with.
Oh, thank you so much. If we don't have any further questions, we will send this recording out to you. Please share it with your colleagues. There'll be a blog, podcast, video. It'll be just everywhere. So we will share it with you. And yeah, thank you so much for coming. I really, really do appreciate it.
Thank you so much, Tara.
Cheers.
Thank you.
You.